Mercy. I'm a specialist intensive care nurse here in the UK for the past 10 years, but I am a public health consultant. I really enjoy working at a health systems level to support change and transformation and to drive care for the best. And I really like these two different worlds of interacting with patients and families and having my clinical work, but also have a much more policy and innovation perspective into the healthcare systems and working in a much more broader and macro level of the healthcare. But today what I really wanted to do is to really take the time to really demystify the intensive care environment for patients and families. For the last 10 years, every time I've been an intensive care nurse, I thought, I wish I had the time to really sit down and explain to my patients and the families what is the intensive care environment look like. Kind of creating that video that I wish I had if suddenly I had somebody in my family and I was not any healthcare professional that I could go to support my understanding of the unit and of the type of work that we do in intensive care and what kind of challenges you might face if you have a family member in intensive care, or if you perhaps have to go to intensive care for following a surgery. So without further ado, I'm going to start my presentation. I really hope that this is useful and it will help you. And if you found this useful, please comment down the section below, but also subscribe, because subscribe is like a thank you for us that we create content, because it will support our work and will make the video much more likely to be seen by other people that are looking for the same type of content. So without further ado, let me start. So today we're gonna kind of demystify the intensive care environment, and really I've developed this kind of presentation to be a guide for families and patients that are really navigating intensive care. I'm not gonna cover like complex things. I'm just gonna explain the common things around intensive care, and I hope that this is kind of a general beginner's guide to a very challenging environment, but also very interesting for healthcare professionals too. So here we are, Demystifying ITU, a guide for patients and families navigating intensive care. Okay, so about me, I've told you all about me. I'm a specialist intensive care nurse here in London. I have 10 years of experience in cardiothoracic intensive care, ECMO. I really enjoy working there, but really my passion beyond in critical care and clinical work is public health, and I'm a healthcare consultant with a lot of interest in healthcare innovation, public health and health systems, and working at a much more macro level to drive change in healthcare. This is what really drives me and drove me for the past 10 years. So what we're going to talk today is a little bit more about the types of intensive care that we might come across. How does the inside of intensive care look like? Type of monitoring and equipment that we might see, communication in ICU, how does it work with families and visits, what are the kind of expectations that you might come across, how does a discharge from ICU look like, and I'm going to share also with you some resources and support that is out there that you might come across, and it can be really, really useful. And obviously, this is not a live session, but I'm wondering if you have any questions, you can put them on the comments below. And then what I can do is partner with charities to see whether we can discuss those in more detail, and I can find you the help that you are looking for. So without further ado, I really created this to really educate you and inform you. I really felt that over the past few years, as a nurse, I didn't have a chance to really think about how can I explain things, how can I take the time to educate my patients. I think I'm always very curious, and I know that there's a lot of people that are very curious, and I know that there's a lot of patients that felt that they've been in intensive care and they might be curious, what were those noise all about? Why was the environment like this? How it took me so much time to improve. I think those are kind of things that it's important to explain to patients, and therefore that's why I'm here. But also to kind of set expectations. Why? Because, as you know, expectations are very difficult to define in environments that are sometimes not a lot of certainty of the pathway, and things have a lot of kind of fiddling around and a lot of roller coasters. So what I really want to show you is the kind of standardized or kind of general expectations that you might come across, and kind of create and help you to create some kind of structures to help you improve the communication between the multidisciplinary teams, help you to support your daily living if suddenly you have somebody in intensive care, and really to share with you some resources that might find useful, where you can find the communities of patients and families that are going through the same experience or have been in the same experience, where you can find content that is relevant and useful and written to patients, for patients, and for their families. So I think, I think there's lots of things good out there, and I want to share those with you if you find them helpful. So let's move on. So what is an intensive care? An intensive care is really, you might find lots of things written down like intensive care, ITU, ICU. It's all the same. But basically think about a hospital that has loads of units. But there's always have to be a unit where you have the most sickest patients. And that's what ICU is. It's a specialized section of the hospital that treats and monitors critically ill patients, and where they can receive more specialized care. Really, the goal there is to stabilize patients, monitor them in a way that it's impossible to monitor them in the wards, and with the correct ratios, with the specialized multidisciplinary teams that specialize in that specific type of care. Or if you had a surgery that is very, very complex, and you might require that type of monitoring for a few days. So this is what is intensive care really. And as you can see, the environment looks like, might have a monitor, might have a computer, might have lots of infusions. Some you might find those fancy places, as you can see in the picture, but not all the ITUs are like this. You might find that the ITU that you're gonna see, it's all in the same space, so there can be a lot of noises and a lot of talk and a lot of weird movements, and it's not sometimes the most calm and peaceful environment, as you can see in these pictures. So I want you to be aware of it. Are ICUs all the same? Well, they really depends, because it differs from hospital to hospital. And I would say that your general district hospitals tend to have kind of the general ICUs, like with the medical and surgical. So you might have patients that went because they had a very nasty chest infection that had to require more respiratory support. Or you might have a patient following a surgery that requires a little bit more monitoring, or any other kind of conditions that might require that your family member or patients might go there. But in more like in the London area and more, university-based hospitals or central hospitals, you might have different types of intensive care units that you might come across. And these can be the surgical ICUs that tend to have just patients following surgery, or kind of more specialized ICUs, such as cardiothoracic, where I specialized in for the past 10 years. It's the area that I really like to work on. And neurology, where I have a very good friend that works there, and he's really passionate about providing care to patients following neurologic events. So for example, cardiothoracic, you can have patients following cardiothoracic surgery like a bypass, or you might have patients following a heart attack, or patients that require ECMO. In neurology, you might have patients with following strokes, following neurological conditions. And you have pediatric and neonatal as well, which are very specific for different types of population. It's not my area of expertise at all, but I'm sure if you're interested, I can bring somebody in to explain you all about all those units and what type of work they do to demystify also the pediatric ICU and neonatal ICU, which are very specific. And also, if you're interested, I can also talk about the cardiothoracic and the neurology. I'm sure that we can find some nurses that can help us discuss further, especially the neurology, and I can demystify for sure the cardiothoracic. Let's move on. So who really works in ICU? Well, I would say that it's everyone, really. It's a lot of people, a lot of multidisciplinary teams that are necessary to really be able to provide that work. You can have the intensivists, so you have the doctors that specialize in intensive care. They tend to be either intensive care consultants or kind of a mix of intensive care consultants with anesthetics background, but it really depends from country to country. There's different standards and specializations, so I would say that's quite complex. But they tend to be specialized doctors or doctors in training that then support the units. Then you might have the nurses. Well, you always have the nurses. They tend to be general nurses that have a few experience on the wards that then go into intensive care and then specialize into intensive care nursing. Just for you to be aware, it might take 3, 4, 5 years until you kind of feel 100% embedded in the intensive care environment and have some kind of stability in terms of knowledge that you can support. It's quite specialized work. You might have advanced nurse practitioners nowadays, especially in the UK, where they kind of support the medical team in more advanced assessments and techniques. And then you also have, physiotherapists that support the rehabilitation of patients, do chest physio. You might have occupational therapists which come to, assess the patients' basic needs and make sure that they can start improving their quality of life as they move out of intensive care and can find tools to adapt their normal routines to the kind of requirements that they have at the time. Then you might have speech therapists and other types of professionals that support the patients, psychologists, chaplains, cleaners that have an essential role in making sure that the space is well cleaned so we can reduce the infections to patients. So as you can see, a lot of other professionals, pharmacists that provide the drugs, review all the medications, porters that bring us all the bloods and take all the requirements that we need. So people that stock the places so we can have the correct material. So loads and loads of people. But for sure you probably just see some of us, but it takes a big team to do what we want. And now I want to show you how does an ICU look like, really. ICU can be really daunting experience if you haven't been before. Really, it's really a weird place, I would say. Maybe it's like me going suddenly to the tube and now having to go to the area that we never go in and see all those pipes, see all those big machineries that I never saw before. Kind of ICU is like that. It's, a symphony of bleeps, hums from sophisticated machinery, and really perhaps actually witnessing a loved one in the state you've never seen him before can really invoke this cascade of emotions and questions. And I think it's really important to kind of speak about it and demystify, because it's not really easy to see somebody that we really love, maybe sedated, maybe a little bit more swollen because of all the drugs, and maybe the patient's not well, or maybe he had some type of surgery where they have lots of drains and lots of machinery. And I think it's important also to prepare for those types of things, because with all those machineries around you and with all those pipes and all those things, sometimes our loved ones don't look exactly the same person, and it can be daunting at first as well. And also surrounded by all that noise is just sometimes can drive you probably crazy and quite alarming. Oh, so many alarms is alarming. But it takes some time to adapt to that environment, but with time, and I think explaining you all the kind of material that we use, the equipment, might make you more familiar with the environment and why do we have this environment, and hopefully make the situation as we go with time a little bit better as much as we can. So this is really what we have. So the units tend to be either individual side rooms if the patient requires a side room, or maybe because of bed management, or they can be like big bays full of different bed spaces. Obviously, as I said, loads of equipment, as you can see here, loads of equipment around you, lots of things that you have to be aware. And also, as we explained, your family member might be in a different situation, so it's having expectations and taking the time to kind of take that all in, because it's not easy. So I found a really good video done by ICU Steps and the London Transformation and Learning Collaborative, which I find that has all the things that you need to know and is very well done. So we're going to use their own resource to show you exactly how does a patient's pace look like, how does a unit look like. Obviously, this is one type of unit. All those units are different across hospitals. It depends on the country that you're in. Maybe you might have a fancy room if you are in a private hospital, or maybe you have a bay with lots of beds and probably not the not the most not the most fancy equipment. But what it matters really is that you have really good care, and that's what is very important. So let me set up this for you. Okay, so here is the patient's bedside that we can see here. So thank you so much, ICU Steps and the London Transformation Learning Collaborative Critical Care Program, because I think this is really well done, and patients can access this online. So I'll share the links. So here is a specific unit that, as you can see, has loads of bed spaces around. It's quite a big base, so as you can see, might be quite busy and quite a lot of blips going on. And this looks like it's nighttime, but you can see here a patient that is kind of ventilated, and here is the bed space that we have. So what you will see is probably something like this when you come around. Obviously, different patients have different needs. So your family member might be intubated, might be on a breathing tube, or might be awake. So it will really depend. Not all the patients have to be asleep and have to be intubated. So just to be aware. But basically, this is the bed space that you might see. You might see a computer. This is our charts where we write everything. Sometimes nowadays might be in the computers. Then you'll have the ventilator generally here. It depends on the units. This is the monitor, and this is the infusion and giving sets. And then there is lots of equipment around that sometimes is for safety checks and all those things. and then our kind of trolleys where we might keep drugs, or we might keep the basic equipment for mouth care, eye care, and other type of equipment, and prepare our drugs. And we have the gloves and the aprons. Very, very important if you come to visit your family member, or if you've been to ICU before, is just to wash your hands as soon as you come in. Patients in ICU tend to have much higher risk of infection, so it's very, very important that you wash your hands thoroughly. And if you are sick, don't come to intensive care to visit. Wait until you get better. And this is kind of the units, one of the types of units that they can show us here. And yeah, basically that's it. So you can see here, for example, this patient, you can see the monitor that monitors their heart rate and their breathing and their blood pressure. And you might hear lots of bleeps and noise. Sometimes they bleeps because, it's a slight change. Sometimes it bleeps faster or in a different way, because we have to keep an eye and see what's going on. And then you have also the ventilator here that will help the patient breathe. So I'm going to show you a different type of view that you can see all those things. And if you are a patient, I never been a patient to ICU, but I've been a patient somewhere else. And this is the type of kind of view that you get as an ICU patient. So you have all these things around. Some patients tell me that they had this kind of snake noise around. And sometimes I can tell you that might be perhaps the suction tubes. So this is our suction units. We tend to have two types of suction. One suction that is a lower one and a higher one. The higher one is to clean all your secretions in your mouth. So we suction like when you go to the dentist. And then the other one sometimes is used for drains. So some people say that they hear a lot of snaky noise, like shh. That can be your suction that you might have. So this is the type of environment that if you've been in ICU, you've probably been in. And lots of noise, lots of things around you. And you might have seen 2-3 nurses around you, 4 or 5 people around you or more. That's all kind of normal in ICU. And but yeah, this is the type of view that perhaps you might have, which is quite different. And obviously the walls don't have anything, so it's not the most pleasant view. So now I'm going to show you the types of equipment that we have, so you can more or less hear the noises and the things that we do. Okay. So I just want to acknowledge that this is not my, it has been done by the London Transformation Learning Collaborative. It's available online. And I think it's such a great resource that they've done with ICU steps that I really wanted to share with you. I think there's no need for me to reinvent the wheel. But basically, it's more or less the same concept. You have the ventilator here. So the ventilator is the machine that helps the patient breathe. Sometimes it helps the patient breathe. Sometimes it takes over his breath. So sometimes the patient might be breathing and the machine helps him to get better. Or sometimes they are so unwell that the lungs need a little bit of rest and the machine takes over completely from the patient and breathes. Then you have the heart monitor here. And as you can see, this is the type of monitoring that we might monitor. So this is your saturation, so your oxygen levels. We measure your heart rate and your ECG pulse, and we measure your blood pressure. So this is the invasive blood pressure. So you might have a few lines in your arms, maybe a line here, so that's, or here or other places. So that's your invasive blood pressure. We tend to put it on your radial artery. And then we measure your entitled CO2 as well to make sure that everything is okay. It really depends what type of procedure you had. You might measure less things, we might measure more things, but it's just to tell you that, we monitor a lot of things. We're very the numbers and the data is very important to us. And then we have also the infusions and some material that you might see here. The other thing you might notice is that you probably might have a catheter. You might not remember it. You might feel, oh, I need to wee all the time. But sometimes we have to remember, oh, you have a catheter, because it might have been put in when you were asleep or when you were in surgery. And basically is a tube that collects your urine. But normally it doesn't stay forever. It just stays for a while. And then you see these kind of pressure bags here on your legs. We call it Fultrans, and they basically help to prevent clots, because what happens is that when you are in intensive care, you stay a long time in bed, so there's a likelihood of increased risk of what we call deep vein thrombosis or clots in your legs, and therefore this is to reduce the risk of those happening. I know that they are not the most comfortable thing in the world, but try your best to have them. You might not have this, you might have some types of socks, which basically do the same thing. And then, as you can see here, you have some lines. So the invasive blood pressure. So your normally tends to be here on the radial artery. You can see that this patient also has some drains. So sometimes following surgery, you might have lots of drains or other types of procedures. And then you might have also some ECG leads, so to monitor your blood pressure. You might have a central line, which is this line here, that goes into a big vessel, because sometimes some drugs that we can't give them peripherally on these types of veins. They have to be through these big veins on your neck or on your leg or on the femoral or jugular vein, because they are quite risky drugs, and sometimes you're in so stronger drugs in a sense that we really need to give you that through much bigger access. So we have to be very, very careful with the way that we manage those lines to avoid the risk of infection, which we tend to do well. And then you also have, some patients might have a nasogastric tube, so this tube here. So when you become very ill, some patients you're not eating, right? If you're intubated, ventilated, we have to give you some food. So this is the way we might give you food. Obviously, there's other patients that have food in other different ways, but this is case to case basis, and then generally speaking, that's the normal type of way that we give. But there's other ways of giving food to patients. And then, if you're family member, if you've been ventilated, you'll be ventilated through having a tube in your mouth that then maybe perhaps goes into a tracheostomy here. If you're weaning down from the ventilator, or if you've been intubated for a very long time, and then they might put a tracheostomy, but it's not necessarily in all the cases. It really depends how long have you been intubated and have to be intubated for. And I think I've covered more or less everything. So this is the bed space. This is the bag that basically creates the pressure to have the lines nice and clean, so then we can monitor your blood pressure and your central venous pressure, which is another number that you don't really need to know, but there's lots of other things that we might monitor in ITU. So I think that's it. You also might have two types of bins, as you can see here, and those will help you to put the correct. So if it's infected, we'll go on the orange one and then the other one as well. So it really depends. But if you have any questions, you can always ask us where should you put your should you put anything that you might need to discard. And that's it. So let's go back to our presentation. So I really hope that this visualizations were really helpful to you and that you find useful. With the monitoring and equipment, the only thing I would like to add is that really it is hard. It's a lot of noises. It's a lot of different bleeps. I'm not going to show you all the bleeps that we have in ICU because there are so many. And I really apologize to all my patients or patients that have been in intensive care, because it's really tedious. And, you know, if you awake 24/7, it's not easy. And I can tell you that sometimes I would go home and still hear all the noises when I went to sleep, and sometimes even waking up in the middle of the night thinking that I overslept looking after my patient, and with the noises of, you know, triggering alarms. So you can see that this really affects us sometimes. Then what I really wanted to talk as well, it's about the communication in ICU. And really, the communication in ICU can be a little bit tricky. And I'm going to say this because, you know, it's not so straightforward as you might think. Sometimes it takes a lot of time. Sometimes you have a different nurse that you never seen before, and then there's another nurse, and then another nurse, and then another nurse, and then another medical team, and then another team, and then another doctor, and then another doctor, and then there's other doctors coming in. So it's quite complicated. What I would say is, generally in ICU, what tends to happen is that you have the normal meetings with the multidisciplinary team every now and then. Also, regular updates, maybe through telephone. When you call, the nurse might give you, he slept well, or he did well, or he's stable. Sometimes it's difficult for us to say because sometimes nothing has changed. So, you know, sometimes the progress is very, very slow. It's not like, oh, it's great, it's already, you know, going home. It takes some time to see progress. Sometimes it's a lot of patience, and also it's also lots of ups and downs, so it's not as straightforward as you might think. What I suggest to you is that you should ask all the questions that you have. And sometimes what might happen is that you go there and it's too busy, it's too stressful, and you forgot all your questions. So what I would say is, when you go back home or after you've seen this video, sit down and just write all the questions that you have. So once you go back, you can bring them to the team. Sometimes it might happen that you call or you want to talk with them, but just the unit is just busy. A patient might came in and is quite unwell. So just be aware that we always do the best as we can to communicate with you, but sometimes things are tricky in the environment that we work in, and it's not as easy sometimes to do it straight away. But we do our best to make sure that you understand what's going on, and if you have any questions, you can always ask. No question is dumb, no question is a bad question. All the questions are good questions, and that's what we are here for. The other thing that you might perhaps ask is, how are the visiting times? How does it work? I would say, generally speaking, it really depends on the unit that you're in, because really each ICU unit has its own policy. Normally saying some units might allow 2 hours, some units might allow more or less. But I think, you have to realize that it's good to have the family around, normally, generally speaking. But there might be some situations that, we have to take and do amendments to the visiting times for many different reasons. But I would say, just ask to the unit, what's your visiting times? What's your protocols? Generally speaking, ask, how is with children. Generally, we don't recommend children to come into the units unless it's something very, very specific. But that's why the teams are there so you can ask questions and really clarify what's the best for them. But also, what I would say to you, when you come and visit, make sure that you wash your hands straight away. highlight this enough. Just wash your hands as soon as you come in. If you are sick, don't come in into the unit, because these patients, generally speaking, tend to be at higher risk of infection, and therefore you want to protect your family member too. I tend to say that if your family member has been in ICU for a long time, I tend to bring, I would tend to ask families to bring like photos of their families, of things that they like, just to bring some kind of personality to the room, and for us also professionals to understand who is the person that we're looking after. But also it's great to see when the patient, starts to wake up, when your family member starts to wake up, we can show them the photos. You can see that the environment has some familiarity, or at least family, some familiarity of faces and things like that. I think that brings much more kind of a family element to the room, which I think it's really nice. But obviously speak with the different ICUs to ask what's their normal routine. But generally speaking, I think that's really, really nice. And sometimes we might do really special things, like we sometimes make adjustments if the patient is well, to go down to the main garden or to see their dog. So sometimes we can do really interesting and engaging things for our family members and patients, which really fulfills also my heart as a healthcare professional to allow those things to happen. Then expectations in ICU. I would say this picture really shows you really what's ICU. I would say that the ICU is like a roller coaster, because it's not as straightforward as you might think. It's a lot of jiggling around between ups and downs. One day is better, one day is not so well, one day is really good, and maybe he started to wind down the ventilator, and the other day might be very tired. It's not as straightforward as you might think. There's lots of ups and downs. It's a roller coaster of emotions for both patients, for both families, and sometimes even for us as healthcare professionals that are there every day. So I would say just look for help if you need help. There is psychologists, there is the chaplain, generally speaking, and there's other healthcare professionals that can help you navigate these journeys. We tend to say that, or in some units you might have a diary of ICU, where the healthcare professionals and the families tend to write a diary for the patient, because generally speaking, if you've been in ICU, some people don't remember anything at all. So they like to have like a diary where they can see what happened to them, and make sense of sometimes some sounds and noises that they might hear. So that really depends on each unit and which type of situation that you're in, but it's something that you also can create to yourself, a diary of that period, so you can kind of reflect on those difficulties and emotions and kind of help you process. But obviously, if you're really struggling, you should look for help to support you through those difficult times. But also healthcare professionals can really help you as much as we can to clarify any questions that you might have, or any concerns that you might have. But no, it's difficult, it's not easy to navigate, it's a roller coaster, and unfortunately that's how it is, and it's just finding ways to navigate those challenges and moving forward. And sometimes, unfortunately, the situation is not the best, and unfortunately not all the patients survive intensive care. Patients are sometimes very, very unwell, but and it's difficult to navigate that journey, and if that's your case, I'm really sorry. But if you are lucky enough to left the ICU, or you had a surgery and you were discharged, sometimes it's very good positive step, of course, and sometimes you might be moved to a normal regular hospital room, or you might step down to like a high dependency unit or a more intensive unit that generally focus more on the rehab process. You might find a little bit strange if you were a patient suddenly having no nurse or one nurse for 6 patients that is not always there, that is not always in front of you. It's a bit weird process that patients tend to say to me that they really struggle with. But it's a positive step, and you should be proud if that's the case. And it takes some time to recover, and once you recover and you get discharged from ICU, things will get a little bit easier generally. But each person has a different journey, a different problem. So the best people to help you navigate that is your healthcare teams, where you can discuss all the ongoing care and recovery plans. What I would say to you is set goals so you can be motivated in order to achieve them. I would say think about short-term and long-term goals with physiotherapists, occupational health therapists, with the nurses, with the doctors. Think about and reflect about which goals are achievable at different time frames. I think that will help you keep motivated and keep going with your rehabilitation process, which often is not very easy. So I think that I would say that will help you. Then what I wanted to say as well is that I really wanted to share resources that I think they are out there. They are really, really good for you to research a little bit more and ask more questions, and also find a community of people that can help you navigate through this process or journey, or even allocate you some type of other resources that can support other areas within your life. So let me show you. So this is the first resource that I want to share, is the ICU Steps. To me, is one of the best resources for patients and families in regards to ICU and patient support, because they really are a charity that want to support patients and their families with tools and resources to keep you more informed. And also they have an online community where you can share the experience, thoughts, and ask any questions you might have. And you have the sign up newsletter. But if you come here, they'll give you much more information about the journey, the introduction, the leaving ICU, how might you feel. So those are kind of things that I really recommend you to read, or ask somebody to help you to find them, because that really goes very in depth, or at least to the basics of how that experience might be, and what are the effects on your body. For example, the weight loss, the breathing, the voice, the skin, the bruising. So all those things are kind of important for you to know. And then you can also find supportive systems here, and the rehab. If you are interested in getting involved in research, you also might sign up to their research volunteer newsletter, which might be useful for you. But also, if you have healthcare professionals, there is also resources that they can bring here to give it to you as well. So this is mainly the best one that I know, that really dedicates and tailors to patients and families. But there's other websites out there. I mean, if you live in the States, if you live in if you live in Europe, there's other resources out there which you can explore. I'll leave some of those here. In Europe, you have the European Society of Intensive Care Medicine, which will recommend you ICU Steps as well, but you can see their resources as well on their website. And then in the United States, you have the Society of Critical Care Medicine and American Association of Critical Care Nurses, and I'm sure there's much more resources. So if you actually know which resources are they and you found them helpful to you, just put them on the comment section below. It might help other people. I don't necessarily know the resources that are in the US, but certainly there's some really good resources out there that you might help. And that's the end of our session. I really hope that you enjoyed it. I really would love if you could subscribe, because subscribe means kind of a thank you to me, and 96% of you don't say thank you to me, and this really helps me to generate really more content to people. And really, if you found this helpful, this subscription, if you click subscription and like, will help tailor my content to the right people and reach more people to help them as well. So I really hope that you found this useful, and please comment down the section below. Was it useful? Do you want more complex details? It's very, very difficult to tailor to your specific situation, because there's lots of different things that can happen. There's lots of different ways why people go into an intensive care, so it's difficult to cover everything. So I had to make it a little bit general and more broad as possible. But certainly we can do more tailored things, but we need to hear what you want to hear. What do you need to understand? So then we can tailor our content as well to you, and make sure that we can educate as much as we can on those specific areas that you're looking for. So I hope you enjoyed it. Don't forget, like and subscribe, and I'll see you in the next video.